Hello, students. Many a times you all come across questions wherein multiple options could be correct. So during that time, it is very much confusing. So as to if all the above options are correct, or A and B is correct, B or C is correct or not. So to clarify such doubts in Prostho, today I will be explaining you few questions. So here we begin with the question which says, which of the following are evaluated when selecting abutment for FPD? So the options given are crown root ratio, root configuration or pedontal surface area. Among this, there are high probability that A or B could be correct, A or C could be correct, D and C could be correct, or all of the above from the options. So here you need to go back to the question and rethink all of the options that suits for the criteria for abutment selection. The answer to this is all of the above. And here you have list of factors that affect abutment selection, starting from root configuration, crown form, crown root ratio, pedontal area, root configuration, root proximities, pedontal disease, pedontal assessment, recession, long axis relationship, and mesially tilted abutments. So, if you get any of these option in your question, you have to make sure that all of these are selected. We go on to our next question, which says patient with a removable partial denture that replaces the incisors may have tendency to whistle when, and you have five options given: when there is increase anterior overlap, when there is decrease in anterior vertical overlap, when there is increase in anterior horizontal overlap, when there is decrease in anterior horizontal overlap, or when the area palatal to the incisor is improperly contoured. And then you have options wherein multiple options could be correct. The answer goes for multiple options. So for a question like this, how should you think? So the answer to this is D, wherein option B, option C and option E are correct. Now I will tell you how. So the answer to this is D, wherein B, C and E options are correct. B says anterior vertical overlap is too slight, C says anterior horizontal overlap is excessive, and E says area palatal to incisor is improperly contoured. Now let's see how. For the whistling to occur, the amount of space between your upper incisors and lower incisors should be normal. If it is not normal, then what it should be, only then a whistle will occur, which means if the space is too small, a whistle can occur, or if the space is too broad and thin or it's too wide, it will be replaced by a shear sound. So what happens when the anterior vertical overlap is too slight, which means vertical overlap is your overbite. So if the overbite is too slight, which means there is excessive space for the air to come out. Next option is anterior horizontal overlap is excessive, which again means anterior horizontal overlap is over jet, wherein the space between your upper anterior and lower anterior is too much. Patient is somewhere in class 2, wherein the amount of air that is coming out is again excessive. So in these cases, the whistle is seen. So apart from this, the palate should be accurately adapted and refined so that it can be worn comfortably, and patient has got its own speech memory. That speech memory should be retained even after the dentures are made. So our next question is a case scenario where there is a pontic which is enveloped with inflamed gingival tissues several weeks after cementation of a fixed partial denture, and there is bleeding on brushing. So this is caused by, you have got five options wherein there is poor oral hygiene, there is insufficient gingival embrasures, there's tissue displacement by the pontic, there's lack of sufficient contact with the ridge, or there's mechanical irritation when the excess cement is not removed. So there could be multiple options that fits correct with the question, but you need to choose the correct answer. The answer to this is A, which says options A, B, C and E are correct. Now let us go back to each option and evaluate. So the patient is having inflamed gingival tissue. One of the most basic reason could be plaque. Now, if the patient is having poor oral hygiene, there is definite chance that there is enough amount of plaque accumulation, and which holds correct. Second is option B, insufficient gingival embrasures. So while fabrication of your FPD, if the gingival embrasures are poorly contoured, which would lead to food lodgement, hence food lodgement will further aggravate plaque. So this option also stands good. Third option is tissue displacement by ponting. So what happens certain time when an impression is made while the underlying tissues are not properly healed, because of which what happens is that after you place an FPD over a period of time, as the tissue heals, it grows back. So when it is growing back, since the FPD or the pontic is retained in its position, it is not going to move. However, the underlying tissues move towards the pontic. There is excessive pressure caused, because of which there is a possible reason or possible chance that the gingival tissues must be inflamed. So this also holds good. Option D is lack of sufficient contact with the ridge. Now this cannot hold good. Why? Because we have something known as sanitary pontic, we have something known as modified ridge lap pontic, where in sanitary pontic there is no contact with the ridge. In modified ridge lap there is only one contact with the ridge. In normal ridge lap it is just 2-point contact with the ridge. So this option does not hold good because we make FPD without contact with the ridge. And our last option is mechanical irritation when excess cement is not removed. Of course, when there is something unwanted that is there beneath your pontic or beneath your FPD, that is in constant irritation or constant touch with your mucosa, it is causing irritation and it is going to lead to inflammation. So here, except option D, all other options hold good. That is why option A is the correct answer. So our next question asks, clinical remount and selective grinding of dentures are done to reduce the vertical dimension of occlusion, reduce the cusp height, reduce the inclination of condylar guidance, to correct the occlusal disharmony created by processing error, or to develop balanced occlusion in all eccentric motions. And you have multiple options here, A, B, C, D, E and F. Now, to answer this question, the very first thing you should know is the definition of clinical remount and selective grinding, or at least why are these procedures done. If you know it, you will be able to answer. The answer to this is F, which says it is done to correct the occlusal disharmony created by processing error and to develop balanced occlusion in all eccentric motions. Why? Because remounting is a procedure that is done to correct the clinical and laboratory inaccuracies in occlusion and establishes the occlusion that ensures even pressure. And why selective grinding is done? It is done to produce occlusal adjustments that were described as a treatment for improving the overall contact, which means to develop occlusal harmony in centric and eccentric motions. So here the options like it is done to reduce the vertical dimension or to cusp height or to change the inclination of condylar guidance, all of this holds wrong. That's why D and E are correct. Now we move on to our next clinical scenario where a thin application of varnish is put over cut surface of prepared tooth, probably a vital prepared tooth, just before cementation of a fixed partial denture with zinc phosphate cement. This will function to increase the possibility of leakage of restoration, to facilitate seating of restoration, or to insulate the tooth against thermal stimuli following insertion, or to reduce the possibility of irritation of pulp due to the acidity of cementing agent. Now again here multiple options could be correct or could not be correct. It's a very direct question. To answer this, you should be knowing why is a varnish used or what is the application of varnish, why is it done. The answer to this is E. E option says that only D is correct. Now D says reduce the possibility of irritation of pulp due to acidity of cementing agent. Now the varnish which is used helps in decreasing the sensitivity of the tooth by forming a physical layer on the top of the tooth which blocks the dentinal tubules. Hence, when a zinc phosphate cement is put which has got phosphoric acid, it is less irritating or there is no damage to the pulp. We have other options like it increases the possibility of leakage of restoration. This does not hold good at all. It facilitates seating of the restoration. Varnish has no role with seating. Third option, it insulates the tooth against thermal stimuli following insertion. So after insertion, obviously there is no thermal stimuli that is going to be put over the tooth. So the only correct answer here is D. It reduces the possibility of irritation of the pulp which will be caused with the phosphoric acid of your zinc phosphate cement. Our next question is, a low sag factor in metal ceramic FPD can cause option A, flow of metal under function loads, B, high abrasion resistance, C, less deformation of bridge span when fired, D, poor metal ceramic bond strength, E, contamination of porcelain. So here again, multiple options could be correct. For this, you have to first know what is a sag factor and what happens when the sag factor is low or when it is high. Sag is the deformation potential of a long span metallic substructures at porcelain firing temperatures under the influence of its own mass. And sag resistance is the ability of dental alloy to resist the flow under its own weight. So the question asked here is, there is a metal ceramic FPD with a low sag factor. Now sag is something which we do not want, as when there is sag there is deformation potential of the long span metallic substructure, and in the question it is said there is low sag, which is a good thing. So the options again, flow of metal under functional loads, no, there will not be flow because the sag is low. Second, high abrasion resistance. Now sag has nothing to do with abrasion resistance, it has to do something with bending. Option C is less deformation of the bridge when span is fired. Now this holds good. Option D is poor metal ceramic bond strength. Nothing to do again with bond strength. E is contamination of porcelain. There is no contamination happening. So the only option which stays good is option C. Option D, which says C only, which is again less deformation of bridge when span is fired. Moving to our next one, flexibility of a clasp arm, RPD clasp arm, is dependent on A, metal used, B, cross section of the metal, C, taper of the clasp arm, or D, length of the clasp arm. Now, there are multiple options. So for this, you need to know the factors those are responsible for the clasp arm flexibility. So all of these factors are responsible for the flexibility of clasp arm, which is the length of the arm, the cross section of the arm, the type of alloy or the metal used, the cross section form, everything. So the answer is E, all of the above. Our next question is to match the block out, where arbitrary is used, where relief is used, where parallel is used, and where shaped is used. So you need to know, to answer this question, you need to know the exact use of every wax and in which scenario are they used. Now this is a very direct question. If you know the use of each wax, you know. If you do not, you get confused. So the answer is B. According to B, arbitrary is used under the gingival crevice. Relief is used below the bar position of linguoplate major connector. Parallel is used beneath all the major connector, and shaped is used to locate the wax pattern of clasp arms. So you need to know the definitions, or at least which is used where. Arbitrary is used on the labial surface and labial undercuts not involving the RPD design. Shaped is used on the buccal and lingual surfaces to locate the wax pattern of the clasp arms. Then we have blockout waxes that will eliminate the undesirable undercut. And then we have parallel blockout that is done on the deep interproximal spaces that needs to be covered beneath the bar clasp arms on the gingival crevice. Now next question is, when taking jaw relations for complete denture, we use the Fox plane. It should be parallel to the FH plane, campus line, interpupillary line, or the SN plane. Now this is a tricky question. We all must have used Fox plane, but it is important that we know which plane parallels to fox plane? Let's see. So the answer is B, according to which option B and C is correct, which means your fox plane is parallel to campus line and interpupillary line. It is very well explained in the image, and you can see whenever a fox plane is placed anteriorly, occlusal plane is parallel to interpupillary line. See, the only motto of placing a fox plane is that we generate occlusal plane. And always remember, occlusal plane should be parallel to the campus plane, which is again there in the posteriorly. The occlusal plane is parallel to the alar tragus line, which is also known as the campus plane. So if you see anteriorly, it is parallel to interpupillary line. If you see posteriorly, it is parallel to the campus plane. Which of the following groups of muscles is influential in molding the lingual border of final mandibular impression for an edentulous patient? And you have got four set of options where there are multiple muscles. Now, to answer this question, it is very crucial that you know how the final impression is made or the border molding is done in the lingual arches, what all movements are done, and upon doing what all movements, which are the muscles that get activated. The answer to this question is C, according to which palatoglossus, superior pharyngeal constrictor, mylohyoid, and genioglossus are the muscles that are influenced during the border molding and lingual impressions of mandibular edentulous patients. Now you can see in this image all the muscles and their directions that are involved during the mandibular impressions. Of course, palatoglossus is involved because it forms the posterior most part. Along with the raphe, it will go upwards towards the maxillary arch. Then superior pharyngeal constrictor is involved because it is present along the raphe posterodistally. Then we have mylohyoid. Of course, mylohyoid is the muscle of floor of the mouth, so that is definitely getting involved, and genioglossus, which itself is the muscle of tongue. Hence, these muscles contribute to the mandibular lingual impression.